Start now.
Thank you very much, and thank you, Oslo. As you can see, we've had a really brilliant time here. This is the view from the top of the Opera House on Tuesday night. After having seen Traviata, I'm sorry, bunked off from one of your meetings, we saw Traviata, and anybody who's still here tonight, and if there are seats, Traviata was spectacular. We've had the most tremendous time here, and I'm very, very grateful. I'm got so much I could talk about on and off the agenda that Annette gave me to talk about. The National Hip Fracture Database has been around a long time, and you've just seen its data being processed in various ways. Hip fracture is a problem, and it's going to remain a problem. We're going to see, and we are seeing, changes in the numbers of patients in the post-COVID period. Though we're meant to be out of COVID, there are still COVID around on the wards. It's not killing people, but it's still disrupting services, and we're still dealing with the aftermath of people's loss of fitness and concerns about how that's impacting on orthopedic services. We're struggling to get people to theatre now, even though COVID is no longer really getting in the way. So this is a world that's still a challenge for us to try and deal with. I have no conflicts of interest. And having got the brief to think about economics of all of this and thinking about the cost of hip fracture, a number of questions sort of cropped up for me. And the first of which is, do we actually have the basic data to do that? And happily, as you've just heard, we do now have the basic data. So when I started 30 years ago, wandering around orthopedic wards trying to work out what was going on as a registrar, I started copying down details of patients' information, and this is my first NHFD. And it was quite hard work. It did mean that I knew more about what was going on for hip fracture than anybody else in the hospital. I then spent a week in casualty department going through the paper records for every patient admitted in the course of the year to work out every fracture that had happened in the Cardiff population. There were 6,000 of them. So you could start trying to do interesting analyses of what's going on and how the service is working. And you could see how a database might actually change how we think about what's going on. I then used those 6,000 patients to write this description of the hip fracture incidence, which became the sort of standard calculation of hip fracture incidence in the UK. Unlike Jenny, when I put all the 6,000 patients into my brand new computer in the 90s and pressed sort by age, I then had to come back the next day to find it out. Things have moved on a bit, and the NHFD is happily moving at a much more plastic speed. So we're able to do things. So that I was frightfully pleased with that paper. I got so bumptious about it that we thought we could predict what's going to happen in the future, and I would recommend that you don't do this. Well, particularly if you're going to hang around long enough for the future to come on, pass you by, and demonstrate that your estimates of fracture incidence were completely way out. We clearly missed all the vertebral fractures back in the day, so our estimates of what was going to happen and what was indeed happening then were wrong. So happily, we can move on, and we've now got up-to-date data. We're not trying to work on estimates of what was going to happen. Better people than I have, including JK, have demonstrated that this is going to be a big problem, particularly in Asia. These are projections by people more competent than myself, and they are coming to pass. So this is a problem we need to understand now. And we need to understand how it works in individual countries. You can't just extrapolate from what's going on in my country. I think we've heard that all week. This is the 2017 paper I just mentioned, where the existing national audits all collaborated to try and paint a clear picture of what's going on around the world, and to try and see whether we can note any similarities in what we're doing. And there are lots of gaps. The Scandinavian registries were very different in what they were focused on at that stage. But if we start thinking about the economics of hip fracture, we're sort of measuring that. And as Petra talked about this morning, the cost of hip fracture is largely wrapped up in length of stay figures. And we've sort of got that, and it's a bit untidy. But those figures are not very easy to compare and make sense of. So if we're going to think about the cost of hip fracture, we need to be a bit more sophisticated. We have moved on since then, and this is the FFN's hip fracture audit SIG paper from this year, identifying areas where we need to work together, and we had a workshop with Rose Penfold talking about cognitive assessment as how we should be approaching that and trying to bring delirium in as part of routine audit. We're very poor at recording more mobility before and after hip fracture. We've got no consistent approach across all the audits, and we've talked about bone treatment as a challenge. But what this paper did show is that we've now got, well, it's a real struggle, because every time I press print to try and send this to a journal, somebody brought out a new international audit, and I had to start again. So we've got 20 different countries with national audits now. So there's a lot of data out there, and these are all very much in a position to start collaborating with the work that Jenny's just talked about. So there's a lot of data to play with, and a long way that we can move on. So we've got data going on. How we capture the full length of time people are in hospital is very difficult, though. So this graph really expresses it quite tidily for you. The short time hospitals where you keep your patients in the acute setting for a very short period are just hospitals with lots of people in rehab, and trying to capture the whole of superspell, not just the orthopedic surgeon's experience of length of stay, but what's going on across the whole patient pathway really matters. And certainly that there's a real sense when they were introducing fast-track transfers in Scandinavia and in the States back in the 1990s, there was a real sense that actually these patients were being moved, and length of stay and overall costs just went up because people were being dumped in wards that weren't really equipped to deal with them in the way that we do with more integrated services now. But understanding cost is going to have to disentangle the whole of superspell. And of course, as Petra talked about this morning, readmissions of that same patient in the same year. So it's not easy to do. The iconic hip fracture group is a Harvard-led team who popped over to England in early 2020. And what they did was take a patient with hip fracture as an example of how different health services worked. And they wanted to do comparisons of how different health services around the country treated a hip fracture, which is exactly the sort of thing I thought was a great idea. And Rona and I met in London. There was Rona and me, and then there were very empty streets. We were just about to go into lockdown at that point. And we talked with them about trying to do that. And they've been working during COVID, doing these comparisons. There's a whole file of different papers looking at these international comparisons. And this is the sort of work it would be nice to think the FFN could do, particularly through Jenny's sort of mechanisms to make comparisons very quickly and powerfully. It's very complicated, though, because people do things in very different ways. That the organisation of healthcare in different countries is so different that direct comparisons are very difficult. And to some extent, these are public administrative data rather than the data that we have in our registries. So this work could have been done very much better, and we could probably get on and do some of this very much better. And it's all very well to worry about whether you're capturing acute stay and rehabilitation, but if you're leaving lots of patients in institutional care for rehabilitation or just permanently, then much of the patient's cost is going to be lost into that. And certainly the NICE guidance, when we built the economic model for NICE, there was a real sense that the investment that was made in a hip fracture program in orthogeriatric-led care paid off in terms of reduced overall cost because of its reduced impact on patients' long-term care needs in their own home or in care homes. And of course, the Norwegians have done this for us. So this very nice study here from Trondheim, where they've looked at the costs of hip fracture care over the course of the whole of the first year, and picking out from that the care home costs, or the long-term care costs, as contributing half of the overall cost of hip fracture. So I think that's a very nice demonstration of where we are. So nursing home care placement was a huge contributor to the overall cost of hip fracture. And I'm not sure that any of our registries are really going to capture that very effectively. And that's something that we do need to think about how we bring into the calculation. So as you can see, in the Norwegian study, huge spike of cost associated with permanent nursing home placement, and huge cost for those individuals. You can do this for huge numbers of different papers. Luckily, somebody else has done it for us. So this Williamson paper, which some of you may have been involved with, is an analysis of 113 studies, which I don't have to tell you about. But they're giving you the same sort of sense of enormous cost associated with the social care costs when added to the health care costs. And then there's a question, if somebody goes to live in a nursing home, how long are they going to live in a nursing home? If we're going to try and calculate the actual cost of a hip fracture, if somebody goes to live in a nursing home, it's not just first-year costs that you'd need to capture more than that. So this is survival curve. This is out of date, happily. My mortality figures are better than this now, but this is a 1,000-patient follow-up that we did more than 10 years ago now. Just looking at the survival curve for people with hip fracture, and we've got about a third of people dying in the first year, another third dying in the next 4 years. So relatively small numbers of people surviving. So the survival curve of patients after hip fracture is very much like the persistence curve of zoledronate after hip fracture. But if people are moved, or if people go to live in residential or nursing home, so these are people who are admitted from home and then placed in nursing or residential home, their survival curves are really quite short. People are surviving 20 months in a nursing home, 30 months in a residential home. And if you multiply that up by the individual care home costs, you get this sort of figure back then, so perhaps 75,000 pounds, so 90,000 euros, something like that, as a cost for the lifetime that somebody would spend in institutional care. Much the same figure for residential or nursing homes. So there's a huge lifetime cost built in there. But of course, many of these patients came from care homes, and it's very easy to miss that. So if you're looking at the cost structure of hip fracture, you do need to remember that this line is not on the zero axis. These patients are above the zero axis. This is just for inpatient hospital costs, but the cost gets pumped up in the year after. But you need to think the same way about their care home placement. So these are definitely out-of-date figures for our mortality, but we had about a quarter of patients being admitted from a care home and about a quarter of the patients going out to a care home after their time in hospital. So actually, new placements in care homes aren't as common as you think, and having seen how ghastly those figures were, I updated this yesterday. So this is National Hip Fracture Database for lots of patients last year, and just looking at where people were admitted from and where they ended up going to. And there's not as much flux as you'd think. There's higher mortality in patients who are admitted from a care home, so we're having that very frail population coming in, we're losing some of them, and then we're replacing others. And actually, if you do the maths, we had about 16% of people came from a care home and 19% went to it. So actually the total number of new care home placements isn't as big as you might think. But it still boils down to an enormous lifetime cost. It's a huge bill for a relatively small number of patients within the context of 70-odd thousand patients. We've got a couple of thousand new care home placements seem to be apparent. But that's a big number, that number. And that sort of brings me on to the last few points that I'd like to finish with. And this issue of who pays for all of this is something that's really worth thinking about, and we have been thinking about it all week. So within the UK, the who pays for your long-term care at home or in care homes differs enormously between the three countries. Care at home in England is very, very expensive. In Wales, it's subsidised. So that even within our country, we've got great differentials in what's happening. In other countries around the world, and we've heard some really touching stories and some great stats from the Fermat work and Matt's contribution in the audit meeting about how the cost impacts on people. And in some situations, this cost is not being met by the state. This cost is going to be met by the family, or the work is going to be done by the families. And we've got no real sense of that. And that really does feel like something that it would be nice for us to collaborate as the FFN, to get a map of exactly how healthcare systems and social care systems treat this typical patient who we're all completely familiar with, and get a sense of how we should be structuring our approach, because what we're trying to sell to governments around the world is going to be different depending on who's picking up different bits of the bill, who pays for the metalwork, who pays for the care, who pays for the hospital length of stay, where does rehab happen. And I don't think we've got a picture of that. I certainly don't have a picture of that in my head. It'd be nice to try and distill that out in the next few weeks. I couldn't not put this slide up. I'm sure there's a reason why it's here in this slide. Oh, yes, because it's very cheap. So we've got this guideline to slap €5 worth of Zeledronate into all of your patients before they go home after their hip fracture. We managed to get it launched on Sunday so that it was available to bring to this meeting. We brought it to the meeting, and the Norwegian just said, yeah, we do that, which is a lovely way to finish the meeting. So this, I think, is something that we are going to see take off around the globe. The Norwegians have been doing it for a long time. It's clearly safe and sensible. There are questions, and Lene's got a lovely trial going on to look at exactly how impactful it is giving very early Zeledronate. But there's no doubt that patients should not be going home without having Zeledronate put into them after a hip fracture. And you can all play with that when you get home. Because five quid for a treatment compared to the huge costs that we're dumping on individual patients in some countries and on poor health economies is a clear win that we should be trying to capture. And then we've seen the Australian version of this earlier in the day. Jackie put up all the reports that she's pumped out from the data from the Australian audits. And the same is there for the other audits around the country. There's an enormous amount of information that's been put in, published, and is available, and we're not making enough use of it. And it is time that we started making more use of this. Lots of data is freely available, and we've got stuff that we can let Jenny play with from our individual patient data sets. But we've also got facilities surveys, we've got descriptions of services, we've got reports like these that need to be pulled together. And actually setting these reports and this information, this understanding of how services are organized against the individual patient data is clearly something that we need to do. But luckily, Celia's done it, so I'll hand over to her.
Yep. You can hear me.